The first time you run a code, you do everything the card tells you to. Compressions 2 inches deep, 100 a minute, epinephrine every 3 to 5 minutes, rhythm check, pulse check, charge, clear. You do all of it right, and the person dies anyway. That happens more often than it doesn't, roughly 3 out of 4 times. Nobody sits you down and explains this part before it happens. You learn it standing over the bed with your hands still on someone's chest while a nurse writes down a time. That time on the chart, somebody has to say it out loud first. For the next 14 years, that somebody is going to be you. Level 1. Medical student. You're in your 3rd year of medical school. Step 1 is behind you. Pass, fail, done. And step 2 is the next mountain. $200,000 of debt sits behind you too. You haven't earned a dollar yet. They send you to the unit, the intensive care unit, where the hospital puts the people who might not make it through the night. Pre-rounds start at 5:30 in the morning, and you get one patient. He's on a ventilator, sedated, and he will not answer a single question you ask him. So you learn to read him another way. The numbers on the screen, the settings on the vent, the bag of fluids, the color of his hands. There's a chair pulled up next to the bed. Nobody is sitting in it. You don't think about why. At 7, you present him to the team in 45 seconds, and the attending moves on to the next bed. The cheat sheet for the ventilator settings stays folded in your coat pocket, soft at the creases from how many times you've pulled it out. You don't understand half of what you're looking at. The pressures, the oxygen percentage, the breaths the machine delivers whether the body wants them or not. It's a language everyone around you already speaks, and you're still sounding out. Halfway through the morning, an alarm goes off down the hall and everyone runs. You run too, and you end up at the back of a crowded room, watching. Someone is on the chest. Someone is pushing drugs. Someone counts down and says a word, and a body jumps on the table. Then the attending looks at the clock and calls it, and a nurse writes down the time, and then, almost all at once, the room empties. You stand there longer than you should. The machines are still running. 6 people moved around that bed without a wasted motion, and it's the most alive you've felt in months. You want in, you want to be the hands on the chest, not the student at the back of the room watching it happen. Then you match. Level 2, intern. $67,000 a year. You're a doctor now technically. First year of internal medicine residency, and the most junior person in the building. First one in, last one out. The team pager rides on your hip, and it goes off during dinner, during your notes, during the one phone call home you've been trying to finish since noon. Step 3 is the exam you study for in the gaps between all of that, which means you barely study for it at all. Most of the job is small. 42 unread messages in the inbox, a potassium that needs fixing at 3 in the morning, a discharge that takes 4 hours of phone calls to nursing homes that don't pick up. On a night shift, you cover the whole floor. 60 patients you've never met, names on a printed list, a pager that treats every one of them as equally urgent at 2 in the morning, a low potassium here, a fever there, a patient who pulled out their own IV line. You learn to sort what can wait from what can't, and you learn it fast, because the nights you get it wrong are the ones you take home with you. You admit a woman with pneumonia who reminds you of your grandmother. You spend an hour getting her comfortable, write a careful note, hand her off to the night team at sign-out, and drive home. You don't find out until the next morning that she coded at 4 in the morning and didn't come back. Nobody tells you on purpose. You just open the chart, and the chart tells you. And then the overhead speaker says code blue, and you're not at the back of the room anymore. You're on the chest. The ribs give under your hands. That's normal. That's the work done correctly. And it still feels like something you'll answer for someday. You run it the way the card says to. The heart comes back for a minute, then quits again. The attending looks at the clock, and then she looks at you, because this time the call is yours. You say it, the time out loud. It's the first time those words have left your own mouth, and they come out level, which is the part that unsettles you afterward. 3 out of 4 codes end exactly here. Of every 100 people whose heart stops inside a hospital, only about 24 walk back out. You didn't learn that number from a lecture. You assembled it yourself, one night at a time. The code isn't the part that stays with you. It's the 20 minutes after. The hallway, the two relatives in yesterday's clothes, the wife whose face already knows before you've said a word. You don't understand that yet. You apply to fellowship. Level 3, Pulmonary and Critical Care Fellow. You matched into pulmonary and critical care. 844 spots in the entire country last year, filled almost to the last seat. One of the most competitive subspecialties in all of internal medicine. 3 more years of training. $78,000 a year, the same pay scale as an intern. 11 years after you first walked into a college lecture hall. The work, though, changes completely. And for a while, this is the best job in the world. You carry the procedure pager now. The first time you intubate someone cleanly, blade in, vocal cords in view, tube through, the chest rising because you told it to, something locks into place that no written exam ever tested. Central lines, the big catheters that go into the veins of the neck and chest. Arterial lines. You stop reading the unit and start running it during the day. You learn to see things on a bedside ultrasound that used to take a radiologist and half a day. A lung that's collapsed, fluid, choking a failing heart. You drain it yourself right there and watch the numbers turn around while your hand is still on the needle. 3 years of this, and the procedures that terrified you as an intern become the steadiest part of the morning. A man comes in blue, drowning in his own lungs. You and the team put him on the ventilator and turn the dials, hour after hour, until the oxygen climbs back. 3 weeks later, he walks out the front entrance on his own feet. He never learns your name, and you don't need him to. The version where it goes right is why you signed up, and sometimes it actually goes right. Half of this specialty isn't even the unit. 1 day a week, you're in clinic. The patients there have lungs scarred from decades of cigarettes or from something nobody can name yet. You thread a scope down the airway to look. The diseases are the slow kind. They never crash, and they never leave. The other days, you're upstairs, where everything crashes. You meet the others up here, too. The anesthesiologists, the surgeons, the emergency doctors who reach this exact unit by completely different roads. You took the long way in, through the lungs. You'd take it again? There's a gap nobody mentions out loud. You're trusted with the sickest people in the hospital, and you're paid like someone fresh out of medical school. 11 years in, the responsibility arrived a decade before the salary will. Then the attending goes home, and they hand you the unit. Level 4, Senior Fellow. Final year of fellowship. After 7 at night, the attending is asleep at home, and you are the most responsible physician in the building for the 20 sickest people in it. If something turns in the unit, the nurse doesn't phone the attending at home. She calls you. 3 in the morning. A patient is crashing, pressure dropping, oxygen dropping, and his family is standing in the hallway in whatever they grabbed off the bedroom floor. You make the calls fast. Intubate him. Start the pressors, the drugs that drag a collapsing blood pressure back off the floor. You stabilize him, barely. And then you do the part you've watched other people do for 9 years. You walk out to the family room, and you find the chair, and you pull it close, and you tell 2 people what is happening to the person they love. There's no attending to hand this off to. The most responsible voice in the room belongs to someone who's 33 and still owes $200,000. By the time the sun comes up, you've done 3 intubations, placed 2 central lines, and admitted a septic patient from the emergency department whose pressure wouldn't hold. You hand the whole night off in a 90-second sign-out, and the attending nods, and you understand that she has no real idea what it cost. There's no line on the sign-out sheet for that. Some nights, nothing happens at all, and those are almost worse. You sit in a dark workroom with cold coffee and 40 charts, waiting for the one call that turns the whole night over. Other nights, 3 patients try to die at once, and you stand in the hallway and decide in seconds whose room you walk into first. Nobody ever trained you for that part. You started doing it, and somewhere along the way, you got good at it. Somewhere in this year, you sit your boards. 2 separate exams, pulmonary disease and critical care medicine. You pass both. The reward for one of the longest training pipelines in medicine is 2 more certificates and the same pager at 3 in the morning. You keep waiting for the weight to lift once you're the attending. It's the thing the senior people hint at and never quite promise. It doesn't lift. The only difference is that there's no longer anyone above you to share it with. You finish. You're the attending now. Level 5, attending intensivist. 14 years after you finished high school, you are a board-certified intensivist. $430,000 a year. 7 days on, 7 days off. You lead the rounds. You run the family meetings. The room is yours. And the job quietly turns over on you. For 14 years, the goal was to keep them alive. Now, the hardest call you make runs the other way, recognizing when one more day of all this is just harm, and saying so out loud to a family that came in praying for a different answer. You sit down across from them. Their father is not going to wake up, and you're the one who has to say so. You recommend taking the breathing tube out. The choice to stop is theirs to make with you, and yours to carry afterward, having been the one who said it first. You get good at these meetings, which is a strange thing to be good at. The trick is to sit down instead of standing over them, to say the word died instead of the soft words that keep a family hoping for a different ending, and to stop talking and let the silence fill the room. Some weeks you don't get to stop. The family wants everything, all of it. Refusing means a fight you'll usually lose, so you keep going. You run compressions on a body you believe you're only hurting. You thread lines into a man who is not going to wake up no matter what you push through them. A doctor in one of the studies on this put it about as plainly as it can be put. It felt like torturing him, and the patient kept saying so. About 1 in 4 intensivists will tell a researcher on the record that they're routinely giving care they believe is wrong. That's the wound this job leaves. Not the exhaustion everyone warns you about, but the slower damage of doing, with your own hands, what you believe is wrong. You keep doing this for the other column, because the other column is just as real. The 30-year-old mother who comes off ECMO, the machine that takes over the blood when the lungs have quit and walks out under her own power. The code that works. The pulse that comes back and holds. The person who gets an entire life back because you happened to be standing in the room when it counted. The save and the one the family wouldn't let you stop land in the same week. Sometimes the same night, the same pair of hands. Then they ask you to run the unit. Level 6, ICU Director. They make you medical director of the unit and then chief of the division, $500,000 a year, an office with a door and your name printed on it. The job changes shape one last time. It isn't a single patient at a bedside anymore. It's bed flow, staffing ratios, sepsis protocols, the morbidity and mortality conference, a budget that doesn't balance. You round in the unit a few weeks a year. The rest of it you spend in a chair in a meeting in front of a screen. Some afternoons you run a tele-ICU. You watch over a dozen units in towns you've never driven to through cameras and a headset. A doctor who shows up as a voice on a speaker in the ceiling. At the Morbidity and Mortality Conference, you stand in front of a room of younger doctors. You walk them through a death that happened on your watch, hunting out loud for the decision that might have gone differently. You're responsible now for the people standing exactly where you used to stand, and a lot of them are not okay. In critical care, roughly half of doctors screen positive for burnout, among the highest of any specialty. You know precisely what's doing it to them because it did it to you, and there's no committee and no protocol that touches the actual cause. You watch a second-year fellow come out of a room where a code just failed and say the time out loud, level, steady, the way you taught her without ever teaching her. You recognize the steadiness. You know exactly what it costs to have it, and you can't give it back to her. The hands that learn to intubate, to thread a line, to steady a crashing room at 3 in the morning. They sit still most of the year now. You have more authority than you've ever held, and most months you don't lay them on a patient once. Even up here, the training never closes out. Every few years, you recertify. Maintenance of certification, they call it, proving again on paper what you've done 10,000 times in person. And then a fellow pages you. There's a patient. There's a family in the hallway. There's a chair. You don't have to walk down there anymore. You have a title, an office, and a whole unit of people whose actual job this is. You go anyway. You find the family room. You pull the chair close. The same kind of chair you noticed 14 years ago, empty beside a bed when you had no idea what it was for. You know now. You tell them. You wait through the long quiet while it lands, and when the monitor finally goes flat, you look up at the clock and you say the time out loud, the way you've said it 1,000 times before. It comes out level. It always comes out level. The part nobody warns you about, back when you're 23 and standing at the back of the room wanting in, isn't how much death you'll see. It's that you'll be the one who has to put a number on it, out loud, in a quiet room, and that it costs you just as much the 1,000th time as it did the first.